Good morning. My name is Jean-Michel Molina from the University of Paris, and it's a pleasure to participate to this symposium today. And I have been asked to give you an update on long-acting antiretrovirals for the treatment of HIV infection. And this is indeed a hot topic. These are my disclosures. Let's review first what are the drugs that are available today or which will be available in the near future for long-acting treatment. It is important to underline that these drugs are going to be available only for treatment-experienced patients, so not for treatment-naive patients. We have parenteral drugs, the combination of cabotegravir, rilpivirine, which are given as intramuscular injections. We have lenacapavir, a drug that is administered subcutaneously. Ibalizumab, it's an IV injection. And in the future, we may have also broadly neutralizing antibodies and implants. There are also drugs like lenacapavir and islatravir that are going to be developed as oral drug given once weekly, a pill once weekly. And in the future, also patches with microneedles, which can deliver the drugs topically. But my talk today will be focused on the new combination of cabotegravir rilpivirine, which has been approved by FDA as well as EMA, but not yet by WHO, because you will see of the implementation issue that are associated with the use of these long-acting drugs. And we know that, despite the success of daily oral treatment for HIV infection, there is a high interest from the patients and the physician as well to use long-acting treatment options to overcome the issue of adherence with a daily pill and the reminding of HIV infection for individuals who have to take a pill every day. So for people using long-acting drugs and who can avoid taking daily pills, they feel a benefit in terms of, in some ways, forgetting about their HIV infection. So there are two drugs, cabotegravir and rilpivirine, which can be combined to provide a strong and potent combination for long-acting injectable treatment. Cabotegravir is an HIV integrase inhibitor, which is similar to dolutegravir, but doesn't have the same high barrier to resistance. It is available as an oral tablet once a day, or as a long-acting intramuscular injection, 200 milligrams per ml, with a half-life of 40 days. The second drug is rilpivirine, an HIV NNRTI, which is also already available as an oral tablet, 25 milligrams per day, or as a long-acting intramuscular injection, 300 milligrams per ml, and the half-life is 90 days. So because these were the two drugs with a long half-life that could be combined together, that's why these two drugs were used in combination, first in the LATE-2 trial, in which it was demonstrated that the combination given every 4 weeks or every 8 weeks was able to maintain suppressed viral replication in people already suppressed. And then I'm going to show you the results of 3 pivotal phase 3 trials, which have demonstrated the effectiveness of this combination with a good safety, and which actually are, the basis of the approval by EMA and FDA. So the first is the FLAIR study, which is a study conducted among treatment-naive patients with any CD4 cell count, viral load above 1,000. And what's very important is that these people don't have hepatitis B co-infection. They have a negative HBs antigen, and that's important for Asia because the combination doesn't have any effectiveness on hepatitis B. So that's important to make sure that these people don't have co-infection. At the same time, it is critical also to exclude people who may have NNRTI resistance mutations, because as you know, rilpivirine has a low genetic barrier for resistance, and any mutation could severely affect its effectiveness. So in this trial, 629 naive patients first receive a triple combination of dolutegravir, abacavir, 3-TC with a single tablet every day for 20 weeks. After 20 weeks, all participants who achieved the viral load below 50 copies per ml were randomized to either the maintenance of DTG abacavir 3-TC for the next 2 years, or the switch to first 4 weeks of oral cabotegravir rilpivirine as a daily pill to just make sure that the tolerability of the combination was good enough. And then the participants receive CAB-LA and rilpivirine LA injections. What's important is it was every 4 weeks, so 1 injection per month. I'm going to show you now the results at week 48. In the left-hand side, you look first at the virologic non-response, those individuals who have a viral load above 50 copies per ml through week 48. And you can see that the proportion was similar, 2.1% with CAB-LA, rilpivirine LA, 2.5% with dolutegravir abacavir. And when you look at the adjusted treatment difference, you can see that the treatment difference was very small, minus 0.4%. And the confidence interval of this difference is way between the non-inferiority margin. So we can conclude that the long-acting treatment was non-inferior to the maintenance of the triple combination of dolutegravir, abacavir, FUTC. If we look now at another endpoint, the rate of virologic success, how many patients maintain the viral load below 50 copy per ml, you can see here that a very high proportion in both arms maintain the viral load below 50 copies, more than 90%, with no difference between the two arms. There was another phase 3 study, the ATLAS study. This study was conducted among people already suppressed under ART, so a number of ART regimen, triple combination. So all patients were randomized when they had viral load below 50 copies per ml. They also had to be HBs antigen negative with no resistance mutations to NNITIs. And they were randomized to either continue their triple oral therapy or to receive oral cabotegravir for 1 month, and then the combination of CAB-LA plus rilpivirine LA given intramuscularly every month. When you look at what happened after 48 weeks, again, when you look at the left-hand side panel, you look at the proportion of patients with virologic non-response. It's 1.6% with CAB-LA, rilpivirine LA versus 1% with the maintenance of the triple regimen. So here again, the treatment difference is small, 0.6%. And the confidence interval, the upper limit is 2.5%, so which is below the 6% non-inferiority margin. So here again, we can claim that the combination given every month was not inferior to the triple oral combination. When you look at the rate of virologic success, there was a very high rate in both arms. It was a bit better with the maintenance of the triple regimen. And this is because, as you could see, there were more participants with no virologic data with CAB-LA, rilpivirine LA, and this was due to discontinuation in these arms. Let's move now to this important study, ATLAS 2M. 2M means 2 months. Because of the inconveniency of giving this injection intramuscularly every month, the company wished to assess whether the combination could be given every 2 months. And that's the rationale for the ATLAS 2M study design. So this study included people already suppressed under either oral treatment or long-acting treatment given every 4 weeks. Same as before, no hepatitis B infection, no NNITI-resistant mutations, and more than 1,000 patients were randomized to receive either cabotegravir rilpivirine as intramuscular injection either every 8 weeks, every 2 months, or every 4 weeks, so every month. And so here we're comparing 2 different dosing regimens in terms of timing, every 2 months, every 1 month. Let's look at the results now. When you look at week 96, at the rate of virologic non-response in the left inside, you could see that with every month, it was 1.1%, whereas with every 8 months, 2.1% in terms of virologic non-response. So the difference on the top of the right-hand side panel is 1%, with the upper bound of the confidence interval being 2.5%. So it's not, it's still non-inferior because the non-inferior margin was 4%. So we could claim non-inferiority. And when you look at the virologic success rate, again, it was very similar more than 90% in both arms. Let's look now at the long-term follow-up of this ATLAS-2M study, which was published now in Clinical Infectious Disease a few months ago. It's at week 152. What do we see here? If you look at the rate of virologic non-response, you could see that it remains the same with cabotegravir rilpivirine every 4 weeks, about 1%, but it has increased with cabotegravir rilpivirine every 8 weeks, increased to 2.7%. So when you look at the treatment difference, it's 1.7%. The upper bound of the confidence interval is 3.3. It's still below 4%, but it's close to 4%. And what these data tell you is that with time, with this combination given every 2 months, there is a small increase in the rate of virologic non-response. And if we look at the people with confirmed virologic failure, those who have a viral load above 200 copies per ml, you have 12 participants, 2.3% when the combination is given every 8 weeks versus 2 participants, 0.4% when it's given every 4 weeks. So 6-fold higher. Also, when people failed, most of the time, in 71%, they develop rilpivirine and or cabotegravir-resistant mutations. So in other words, according to the study design, it's still non-inferior to give the injection every 2 months, but you have to be aware that in a few participants, 2.3%, you can develop, virologic failure with resistance, even if you receive the injection on time. And, with time, this risk still exists. So we should keep in mind this issue. Finally, I'd like to show briefly the results of the SOLAR trial, which compare the combination of bictegravir TAF versus the injection every 2 months. And this is a study conducted in people already receiving big TAF FTC, already suppressed, and people were randomized to continuing with big TAF FTC or to switch to the injection. And here again, when you look at the rate of virologic non-response, 1% versus minus 1%. So the adjusted difference is limited and is also non-inferior to the 4% defined. And in terms of virologic success, very high rate, more than 90% in both arms. So if we look at the rate of confirmed virologic failure, we have only 3 with the injections, but we have none with the oral combination. So here again, there is a price to pay to receive these injections. There is a small rate of failure, but we need to know that this is possible. In terms of safety, the safety was pretty good and very, very few treatment-related serious adverse events. And when you look at the discontinuation for injection site reaction, because the injection could be a little bit painful, only 2% of those receiving the injection every 2 months discontinue the study because of adverse events. So a summary of these data was done to assess what are the baseline factors that could be associated with the increased risk of virologic failure when you receive the combination of cabotegravir and rilpivirine. And these parameters are listed here. If you have rilpivirine resistance mutation at baseline before the switch to the injection, the odds ratio for confirmed virologic failure is 40, so very high risk. So you really need to avoid using this combination in people who have rilpivirine RAM resistance. The second parameter is the rilpivirine trough level at week 8. So if we have a low trough level, you increase the risk of virologic failure. So you may want to check rilpivirine trough level in people receiving the combination. Also, and this is all related, people who have an HIV subtype A6 or A1 have the polymorphism in their reverse transcriptase, which is associated with a lower response to rilpivirine. So not surprisingly, the odds ratio for confirmed virologic failure are increased if you have someone with a subtype A6 or A1 to be treated with this combination. And finally, people with a higher BMI have a higher risk of virologic failure, and higher BMI is correlated in some ways to the cabotegravir TRAF concentrations. So when you have no baseline risk factors, the risk of virologic failure with combination is very low. But if you have more than 1, so 2 or more of these baseline risk factors, then the risk of virologic failure is very high. Recently, the European guidelines have implemented long-acting intramuscular cabotegravir rilpivirine in their guidelines in people already suppressed, when there is no history of resistance and no hepatitis B co-infection, and we recommend that people are immune versus hepatitis B so that they would not also acquire hepatitis B during the treatment with Caberlet rilpivirine LA. And as you may know, you start with the first injection of 600 milligram of cabotegravir, 900 milligram of rilpivirine. You repeat the injection at 1 month and then every 2 months. There are a couple of recommendations for use of cabotegravir rilpivirine. First, you have to document virologic suppression for at least 3 months with a viral load below 50 copies per ml. You have to make sure that there are no baseline resistance to either medications, no history of prior virologic failure, no active HPV infection, unless you have, in addition, a treatment, an oral treatment for hepatitis B, that women are not pregnant or not planning to become pregnant because we don't have yet enough data with cabotegravir in pregnant women, that participants would not receive medication with drug-drug interactions, such as rifampin, for example. You would avoid people who have an HIV subtype A6 or A1 and people with high BMI. And before initiation of the injection, you may or may not receive the combination of cabotegravir and rilpivirine orally for 1 month, in case you want to make sure that the safety of the regimen is good enough, but this is not mandatory at this point. Let's switch now to other long-acting treatments that are less frequently used, but are useful in people treatment experience with HIV, but who are failing treatment. So the two next drugs are drugs that can be available or used in people failing current treatment. The first is ibalizumab. Ibalizumab is a monoclonal antibody which binds to the CD4 receptor on the T cells and blocks viral entry. It has been assessed in a single arm open label phase 3 trial in which patients failing their current treatment were enrolled in the study, received ibalizumab at day 7, and the primary endpoint was seen at day 14, so 7 days later. And after day 14, the optimized background regimen was given to these patients. So ibalizumab was continued every 2 weeks IV, and in addition to an optimized background regimen. And what you can see here is the primary outcome of the study at day 14. In the red box here, you have 83% of the patients who had more than a 0.5 log decline in HIV RNA in plasma, which is great, which shows that this is an active antiretroviral drug. And you could see that over time, the proportion of people who achieved the viral load below 50 copies per ml increased from 43% at week 25 to 56% at week 96. But you have to remember that these patients also had an optimizing background regimen starting at day 14. The second drug is lenacapavir, which is the first-in-class capsid inhibitor, which actually had many different steps of the viral cycle and retains full activity against viruses that have resistance to the other classes. This drug can be given orally and subcutaneously, and in this phase 3 trial, if you look at the top panel, patients failing treatment received for the first 14 days oral lenacapavir in addition to their failing regimen or a placebo. Only 36 patients were enrolled in this study. And after 14 days, they received subcutaneous lenacapavir every 6 months subcutaneously, in addition to the optimized background regimen. And in both arms, everybody switched to lenacapavir plus optimized background regimen. What happened is that, as you can see at week 14, there was a decline in the viral load by 2 log with the addition of lenacapavir versus no change with placebo. So this data demonstrated the very high potency of lenacapavir when added to a failing regimen. A few patients develop resistance to lenacapavir. We don't still understand what's the meaning of this resistance. If you look at the efficacy over time, you can see that a very high proportion, up to 86% of the participants at week 52, maintain a viral load below 200 copies per ml, 83 below 50 copies. Similarly, you have a nice increase in CD4 T cells. And when you look at the long-term data, you see some people having resistance, but even with the resistance, some individuals may continue to suppress the viral load. And in terms of tolerability, the most frequent safety issue were injection site reaction, and particularly nodules and induration. We could last a few weeks. So in summary, I think long-acting agents could be game changer for the treatment of HIV infection. We have today cabotegravir, rilpivirine intramuscular given every 8 weeks in virologic suppressed patients. Lenacapavir and ibalizumab can be given subcutaneously or IV in patients with multi-drug resistance. And in the future, we'll have combination of these small molecules with neutralizing antibodies, maybe for twice-a-year injections, and also islatravir and lenacapavir as a weekly pill. And I thank you for your attention.